So I'm going to talk about just the concept of who makes a good candidate for surgery and why you do surgery and what's the intention. So I don't think at a sinus course now in 2019, this patient here with an isolated maxillary, isolated frontal, isolated sphenoid, isolated frontal, and isolated localized and anatomically discrete sinus disease, I think these patients have a condition which is so anatomically discrete, it's not really part of a broader airway condition. Yeah, and I think we acknowledge this, that these patients essentially don't have a broader inflammatory problem, and probably what's happening is related to local anatomy. And that's fine. You know, ENT surgeons love seeing this. We know how to fix this. This is not the challenge. These are not the patients who come back all the time. Nor is it, in my opinion, the average patient. The average patient looks a bit more like this. They have patchy and diffuse changes. And the idea that somehow multiple synchronous bilateral osteal or mechanical problems are contributing here is false. We know that someone who looks like this is really someone who is an inflammatory airway sufferer. Now, it's not to say they may not get some mechanical issues such as barotrauma when they fly, but the heart of the condition that's happening is not related primarily to local anatomy. We acknowledge this for a long time now. We understand that there are some people who sit on this end of the spectrum which we call chronic sinus disease, and we do very simple, isolated, anatomically discrete procedures for them. But on this end of the spectrum, where people have diffuse changes, they don't have to look as bad as this. We do a different type of surgery where the surgeries, like Aries discussed, it's about creating a simple open cavity that we can then treat medically. And we do align what surgery we do. So I don't ever do OMC or limited anatomical surgery for someone with diffuse disease. We know that's not going to help them. And likewise, it's unnecessary to do extensive surgery for someone who has a local or focal anatomical problem. So we try to marry up our surgery with what condition we're trying to treat. Now, I just want to talk about inflammatory patients. So I'm almost going to dismiss the left side of the spectrum there, because I think we know how to do that. You can adapt your surgical skills to treat those patients. I want to talk about upper airway inflammation, this patient here. And really, in my mind, this is the common patient when you see them anatomically and we assess them in a clinic. How do we predict, though, what we're really treating here? You know, we divide sinus disease into polyps, non-polyps. Sometimes we'll say, oh, is there turbinate hypertrophy or secretions or polyps present? But really, our specialty has failed to move beyond even the simplest of descriptions of how that inflammatory patient looks. And I'm going to present a little bit of data today on how we separate that out. Now, people are trying to do this in our specialty. You know, what are endotypes and phenotypes? And this is from a Galen study in Europe where they're trying to do a whole lot of biomarkers to work out, you know, what type of disease are we really treating? Because we know that when we see patients with chronic airway disease, it's not all one condition. We know that there's several different versions. You might broadly classify them into IL-5 negative and positive, eosinophilic, non-eosinophilic, but really we still don't have something we can translate to clinical practice. Now, something I've learned over the years is that respiratory physicians are smarter than ENT doctors, and they've been at it for a lot longer than we have, and they understand that everything happens in the lower airway is not a plumbing or blockage problem. And they even understood that with chronic inflammatory disease, there's a whole range of different inflammatory states that can give an asthma-like picture. And one of those people is Sally Wenzel. So she wrote this article about asthma phenotypes, where on the vertical axis it's severity, and on the horizontal axis it's age of onset. And it really represents a description of phenotypes that are Th2 driven, whether you call that allergic or eosinophilic, through to not less Th2 driven as age goes on. And I'm going to take Sally's diagram here and use it to describe three phenotypes that I think you can take away from this course and apply it to your clinical practice. The first one is people who come and see you and say, I've had sinusitis my whole life, they're generally young, and they describe having rhinitis and inhalant allergy. And this is my allergic group. And they usually have childhood asthma. So this is a group who have childhood asthma. Often when they present in their 20s and 30s with sinus dysfunction, they often have barotrauma. They rarely have severe sinus disease. And often their asthma has become almost quiescent or minimal. Now, the biggest marker for these patients is this. This is middle turbinate head edema. Now, erroneously, some people refer to this as polyps. This is not polyps. This is edema coming off the turbinate heads. And it is a very strong marker of inhalant allergy. And once you start looking for it, you'll see it more often. Anisa Hamazan, who was a PhD with us a couple of years ago, wrote 10 publications in total regarding all of this thing. And she did this publication looking at describing the different degrees of turbinate edema, even like little focal areas like this through to polypoid change. And she showed that if you can see middle turbinate head edema, it is incredibly strong positive predictive value that you have inhalant allergy. The absence of it is less so it's not very sensitive, but if you can see it there, it means you essentially have inhalant allergy until proven otherwise. And so when I'm presented with patients who come in and look like this, terrible polypoid change coming from the turbinate, not out of the sinus, it's coming from the turbinate, this is not someone who has a broader inflammatory condition. Their condition is actually limited to their nasal airway. And this is what they often look like. So on the left-hand side here, they have a grade 3 polyp. And you can see it on plan B, the scan, but when you go back to the sinuses, they're completely normal. So this is not nasal polyposis in its traditional. This is not CRS with nasal polyposis. This is simply just very dependent edema coming from the turbinate head in someone with bad allergy. Now, if you understand that, you'll understand this new description of a phenotype which is called central compartment atopic disease. So this is where you could imagine people have so much of this polypoid change around their turbinates and on the septum, and there's an association here with what Eri is referring to as RIA. They then get this pattern on their scans. It's not really sinus disease. All their superior and lateral parts of their sinuses are normal, but all their disease is centered in the middle here. They get a bit of trapping of mucus, but it's all centered in the middle. And this has been referred to as central compartment atopic disease, because the patients get a little bit of sinus change, but it's almost like what's referred to as a black halo, as it was once described by Valerie Lunn. Now, this is one of Anisa's studies again. She looked at 100 patients and she characterized where was the thickening in their sinus cavity, and she came up with these phenotypes to say, was there a difference in the pattern of sinus disease? And she broke the group of the patients into the atopic and sensitized. No surprises that the sensitized group were younger. And then she showed that actually John Delgadio's original description of this centrally limited sinus disease, or the black halo, was what really came up as the strongest indicator that you were allergically sensitized. And even though you might look at this and say it's 70 versus 45%, it's not that huge. The fact that you can pick someone's allergic sensitization from a CT scan, considering all the confounding factors, I think is amazing. But it's very important. You know, John Delgadio, myself, and Nisa, there's a few people who've done research in this field, and they all speak very similar language. They all believe it. But you know, it's always nice to have validation from another group. This is Ed McCool's group, completely unrelated. He talked about this phenomenon called middle turbinate polyposis, right? He's describing inhalant allergy. So he said, let's take real polyp patients where the polyps are coming from the sinus, where there's sinus inflammation, versus people who have this polypoid change on their turbinate, and say, what's different about them? Well, essentially they're younger, like you would expect in an allergic group. They're more likely to have a true classic allergic rhinitis and less likely to have aspirin-sensitive disease. Very typical for simply people with inhalant allergy. And not surprisingly, their actual degree of sinus inflammation was relatively small compared to people who had true nasal polyposis and true sinus inflammation. So this is a scan that was sent to me by a fellow who immediately returned back to Alaska and said, I had a 19-year-old sent to me with sinus disease. Well, this is not sinus disease. This 19-year-old, as you can almost tell by their age, has essentially just thickening. They've got chronic inhalant allergy. And the scan here, there's this endoscopy on the right, it's a different person, but shows that the edema and swelling that you start to see in inhalant allergy. And I think once you start looking for it, it becomes very apparent in your practice. But I think in times gone by, I saw these patients with grade 3 polyps and would take them to surgery and remove them, and you get into the ethmoid, and the ethmoid was near normal, and you think, well, golly, that was just a lucky day. And I didn't even think about it, but I think in the last 10 years of practice, we understand that this is a different entity altogether. Now, what about this disease where you are completely well and you get a viral event, and then ever since then you've had terrible asthma, you've lost your smell, and you've got a chronic cold? Or someone who says, I had allergy when I was younger and I was well for a while, and then in my 40s it came back. This person has true eosinophilic airway inflammation. You give them corticosteroids and they think it's fantastic, but the minute they stop it, it all flares up again. And these patients look different. They don't have centrally limited disease. They've got this diffuse thickening. And if you look up at their middle meatus, it doesn't look anything like the previous patient. They've got eosinophilic mucin, edema, and swelling. This is because these patients, if you look on tissue assessment, which we do now routinely here in Sydney, we're very fortunate to have a group of pathology labs which all are prepared to give a histopathology report that gives us some feel for the degree of tissue eosinophilia, eosinophil aggregates in the mucin, charcolating crystals, and evidence of eosinophil activation, that it's an inflammatory eosinophilic condition in these patients, and we really use tissue to make that final diagnosis. And the biggest problem for these patients is that when you use a spray or a special drop, as Aries described, these are treatments, as you can see myself spraying my nose, they are treatments for the nasal cavity. They are not sinus treatments. And when people have terrible eosinophilic disease, they have disease here, back here, up in here, and this is where they need treatment. They need treatment back in here as well, and they simply don't get it when they have topical treatment. And it's this common issue. Where does the anti-inflammatory therapy need to go? It doesn't need to go here. It needs to go here in allergy and rhinitis, but it needs to go here for people with severe eosinophilic airway inflammation. You can get it in there through tablets, but of course when you give them oral steroid, you deliver just as much to their big toe and their liver and their bones as you do their airway, but they love it. They can tell you, some patients of mine will say, if I could just be on prednisone my whole life, it'd be perfect. And the problem is the minute they stop the prednisone and someone puts them on a simple nasal spray, it just doesn't get in there. And that's why they fail. So the way we do it locally now is we create a simple cavity that we then use a corticosteroid irrigation to deliver the treatment effectively. Now, for many years, this was hinted at from research in the delivery of topical therapies, how we were managing patients. But Ray Sachs and I, proudly with Larry Kalesh's help, put together an RCT that took us several years to run. It was published in 2018, and it essentially showed, I'm going to scoot over the study for the sake of time, but we gave everyone an irrigation and a spray, but in one group of patients they used a mometasone solution, and the other group was placebo, and the other group they used a mometasone spray, and the other group placebo. So they both did a spray or an irrigation and a spray in that order, but they didn't know where the active agent was being delivered in the irrigation or spray. And this study clearly showed that if you deliver it through an irrigation, you do significantly better than if you do it as a simple spray. Now this is just one of the slides. This is nasal blockage between baseline and a year out. The blue is the spray group and the orange is the irrigation group. And you can see that everyone in the orange group does better. But what's important here is that you can see by about a year out, people in the spray group begin to fail. And that's what we see clinically. And I would have loved to have run this study if I had the will and the money and things for 2 years and 3 years. But I think what you would have seen is that more and more patients left on a local treatment such as a simple spray would essentially fail over time because they're just not delivering anti-inflammatory therapy. Now, it's very important. So this is one of our patients from the trials. This is what we end up doing. We create a simple cavity for them. Now, it's important to put this in because we have, other than non-surgeons here, we've got respiratory physicians, immunologists. You might think a simple interpretation of that advice is that somehow you then need to operate on everyone to treat sinus disease. That's not quite true. So just like in asthma, not every asthmatic needs to immediately go on inhalers. Some asthmatics, you can just talk to them about, weight reduction, exercise, fitness levels. And this is someone who gets mild nasal mucus, mild congestion. You might just give them a saline irrigation. This is where we probably start to see patients in medical care, like an asthmatic who doesn't need an asthma inhaler or treatment any time of the year, but the minute they get a viral event, they get wheezy and have a cough. Well, that's when someone you might talk to them about using Ventolin or a bronchodilator during a viral event. You might talk to them even using a temporary corticosteroid inhaler for a few weeks while they have a viral event. And we start to see these patients in the upper airway, but they present with congestion. So sometimes nasal steroid sprays help reduce the congestion. They get secondary infections. Everything gets so inflamed that it gets secondarily colonized. And therefore, they make good patients who would get occasional antibiotics. And then this is when they start to see ENT surgeons, where their airway is so inflamed that they almost have a lot of inflammation leading from one event to another. And they're constantly seeking systemic treatment, usually in the form of antibiotics or corticosteroids. And you might ask yourself, how long can you treat someone with just intermittent systemic treatment? Well, probably 2 to 3 weeks at a time for 2 or 3 times a year is about what I recommend. And at that point, there's a bit of evidence that if you're using systemic therapy now to manage an airway problem, that you start to see side effects from, if you do that year in, year out, from especially corticosteroid use. And so it's at this point here, this threshold, that I talk to people about having surgery. And the goal is, it's not that you need surgery to treat it, but at this point you're going to shift your care of your condition away from systemic tablets and onto a local therapy. So that's the whole goal of that. And here's the last group. So this is this non-eosinophilic group. And we see this in lower airways as well. People who come in, they're often females, they're often elderly, they're often obese, they don't respond to corticosteroids very well. And there's an upper airway equivalent to this, and this is this non-eosinophilic. You've got to be careful, it's not neutrophilic, but just low eosinophilic airway inflammation. They almost always have asthma as well, or poorly controlled low airway symptoms. And this is a woman who came to see me many years ago. She said she had surgery, and I said, look, no problems, I know what to do. We'll do a big wide surgery and put you on a corticosteroid irrigation. And this is what she looked like 3 months after my treatment. And I didn't really understand why this patient hadn't improved. They hadn't responded at all. I give her a course of oral corticosteroids, she didn't respond at all. And then we put these patients on macrolides, and it makes an enormous difference. But we didn't know who was the right person to treat. And we fortuitously have a tissue biopsy on these patients. And when we looked back at the tissue biopsy, rather than just looking at these suggested phenotypes, this lady here really had no eosinophilia despite having a broader airway condition. So she had lung problems as well as sinus. And we put her on a macrolide, and this is the response you see in this group. Now, you don't need to be Japanese to understand the importance of macrolides in managing chronic airway conditions. There is obviously a well-beaten path in lower airway disease where macrolides have really turned around conditions such as diffuse panbronchiolitis. But understanding which group it was in the upper airway that would benefit was very ambiguous. And so we did a little study to show, we said who is a macrolide responder? I don't use it that often, but we went back, Gretchen Oakley did this study where she went back and said, okay, let's look at the patients we've all given macrolides to, and let's look for those people who had this amazing response, where it completely normalizes, and let's see what's the difference between the responders and those who didn't respond to macrolide therapy. There's only 30-odd patients here, and what was most important here is that if you were a macrolide responder, you would likely to have low serum eosinophilia, low tissue eosinophilia, and you hadn't yet had some remodeling events like squamous metaplasia kick in. And so a summary there is that the macrolide responder, if you're looking to use this treatment in upper airway disease, it's really someone who has probably corticosteroid insensitive, who's a slightly older patient, and they have a low serum and low tissue eosinophilia. These are the sort of critical factors in which you might look for the appropriate macrolide responder. And maybe haven't had it so long that they start to get remodeling. So just to summarize here, so for an inflammatory sinus patient, we still do create a simple, what we refer to as a neo-sinus cavity. And we do it for several reasons. It allows for topical access. It overcomes mucus stasis. A lot of these conditions are hypersecurity, and allows to wash out the mucus. Overcomes secondary obstructive phenomena, pressure, barotrauma, and does reduce probably the inflammatory load. You're making the whole surface area slightly smaller. And then what I try to do is I try to place my patients for now in these 3 groups. I say, based on their age and how they present, if they're simply allergic, they're the sort of patients after surgery you really need to treat their allergy aggressively. Put them on immunotherapy. They can use a simple spray or corticosteroid irrigation. Very occasionally, Jan and I have had used omalizumab in people with very high IgEs and have atopic disease. This is probably the common group. This is the group that we use corticosteroid irrigations And this is the group that we did our trial on, this group. And they occasionally used low-dose oral prednisone for long periods of time in the past. And we've probably transitioned most of those patients to biologics, and Connie's going to speak about that. And then I do look out this final group, slightly older, corticosteroid insensitive group, whose pathology, despite them looking like polyp patients, comes back as non-eosinophilic, low eosinophilic, and that's where we use macrolides. And my success, I believe now, with a tissue-driven macrolide treatment is highly successful, whereas macrolides was something that were just once thrown at the patient like kitchen sink, trying to make them better, with little direction as who was the right candidate. Thank you very much.